distinct pleasure for me to be here with Dr. Roth. Tom Roth has been a major contributor, I would say personally a unique contributor with Dr. Dement to the establishment and growth to the sleep medicine field. Since 1978, when Dr. Roth founded and managed for many years the sleep medicine research and clinic at Henry Ford Hospital, he has remained there. He has been an officer, president, leader of all and the various sleep organizations in America and the world, including the Sleep Research Society, what used to be the Association of Sleep Disorder Centers, the APSS, the National Sleep Foundation. He was the chairman of the National Center of Sleep Disorders and Research Advisory Board when it started. Tom is a prolific writer, editor, mentor, colleague, and friend to so many in the field. It is a pleasure to welcome you, Tom.
Thank you. It's a pleasure. But I want to point out, the reason I'm a prolific writer is I have colleagues like Dr. Rosenthal who write papers and put my name on them.
Oh, well, that's very gracious. I wish it would be truth, but we will go from there. Tom, from your unique perspective, I don't want to dwell on the past. Those who have been around you know about your leadership and your many accomplishments. From your unique perspective, what's the status of sleep medicine today?
You know, I think sleep medicine today, you know, has, you know, gone from infancy to being established, right? So we sort of lived at a time early on when people thought sleep apnea it was called Pickwickian disease because nobody had it. You know, when I was recruited in 1978, as I mentioned, to Henry Ford Hospital, nobody thought sleep apnea was a common thing. Today, we know that sleep apnea is a common thing, but the therapeutics are a problem. In other words, so one of the things that you know we've discussed in the past is we have things called sleep apnea, and we treat it as a unitary entity, and it's not. We have something called insomnia, and it's a unitary entity, it's not. You know, the big catchword in 2020 is precision medicine. And I think that's where sleep medicine has to go, into precision medicine. How do you treat Mr. Jones, Mrs. Robertson, who has insomnia or sleep apnea? Are they all treated the same? I mean, the problem with CPAP is it treats all apnea, no matter what the reason is. And that's not good, because we're not getting a fundamental problem.
So
at some level, one can say the same thing about high doses of hypnotics. It doesn't get at the issue.
And with that lead, this interview, we will really be following your thoughts on centered on insomnia. And
right.
In that context, in your opinion, what are the critical and optional elements in the clinical assessment of a patient with insomnia?
Well, it seems to me that the critical elements, A, is one, to find out the cause, you know, it was the diagnosis of insomnia is a bunch of things, you know, so it's 3 times a week, blah, 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 despite adequate opportunity and circumstances, sleep. So the first thing a doctor has to find out, or clinician has to find out, is do they have adequate opportunity and circumstances sleep? Is the sleep environment properly? And all those things are critical. Not a big deal, and 90% of the time to be there. You know, very clearly, if you sleep in a noisy environment, that's not insomnia, that's a noisy environment. So you have to sort of figure out, so I think that's a critical thing. The next thing to figure out is the regularity of the person's sleep problem. You know, I think sleep diaries are not very complicated. And I think that's something which should be done routinely. Just keep a sleep log. And many patients will find out that they're sleeping better than they thought. So I think a sleep log is a wonderful thing.
How about
And so,
actigraphy, in your opinion?
well, I'm going to go to optional, because that's not 100%. I think, if you look at the Insomnia Severity Index, I think that's a really wonderful tool, because you then can compare your patient to a variety of other. It's a standardized tool. So I think if you give them the Insomnia Severity Index, you ought to be able to read it as a clinician and ask those questions. So I think getting a clear history of the nature of the disturbed sleep and the daytime consequences, I think those are the critical elements. Now, what's really nice is if you can get an actigraph on somebody. The other thing that's critical is ruling out causes of insomnia. Things like sleep apnea. There's an incredibly high prevalence of sleep apnea in patients complaining of insomnia. There's a large literature on that. So things like the stop-bang theory. So you really have to ask questions about snoring. It's very important to understand that in elderly patients, obesity, we all think of sleep apnea as big 35-year-old men with big necks. Well, elderly people have the highest prevalence of sleep apnea, but obesity is not a risk factor. So you really have to ask questions about things like snoring and things like that. So I think at the end of the day, I think the important thing to recognize is you have to spend some time to get an insomnia history.
Let me ask you, in that context, it occurs to me something that happens with some frequency. You mentioned the consequences to insomnia, and that's an important element, even included in the diagnostic considerations. What about the patient who is just frustrated by their sleep and you do not identify a clear consequence? Memory is not the same, but they are aging. They don't feel rested, but there's no sleepiness. Is that person in need to have therapeutic intervention beyond sleep hygiene?
I think you ask what I think is just a critically important question. A critically important question. One of the things that all of us were taught is that insomnia goes up with age. Okay? Well, it turns out insomnia does not go up with age. As you pointed out, I have difficulty sleeping at night goes up with age. But then in the diagnostic classification of insomnia, the second question is, how does this affect you during the day? And if you take 35-year-olds who have difficulty falling asleep and staying asleep, it's about 95%. If you take people in their 70s, only half of them say that it affects them during the day. So you have a patient who walks in there who's 75 years old, who says, I wake up 10 times a night, I go to the bathroom, I only sleep about 5 hours a night. Does it affect you? Nah, not a whole lot. It doesn't really impair me. Now, what do you do with that patient? And that, which is what you asked me. And I think that's a really, really good, important question. So let's think of it, one, do patient, and this is what you have to get at, is are people in their 70s telling you it doesn't affect them during the day because I'm 70, I'm not supposed to remember things. So they misattribute it to aging. So the first thing you have to do is make a determination whether they really are impaired during the day. Are you sleeping? No, I'm never sleeping. Well, have you ever taken a nap? Have you ever fallen asleep in a movie? Have you ever fallen asleep in a church? So I think you have to get a history, a clear history of whether they're impaired during the day. So, but let's say they're not impaired. Let's just take the hypothesis that they can't sleep, but they're fine during the day. So the question really then becomes, you treat a person who has difficulty sleeping but has no daytime impairment? And that's a great question. I think of people staying awake during the night as a painful experience. And for me, treating that insomnia or that sleep disturbance, which is not insomnia, which is no time impairment, is the same as the use of analgesic for pain. So lying, if you're a 72-year-old man, woman, lying in bed in a house by yourself, wide awake for 2-3 hours, that's painful. Yeah. And I think treating that with no other goal other than getting rid of that wake time is valuable.
And having shepherded so many clinical trials in insomnia, I think in that regard, very few people have the level of expertise and depth in the understanding of of the pharmacological management of insomnia. Just for the audience who will be watching this, Tom really shepherded through all of the initial studies, starting, if I recall correctly, triazolam was perhaps the first modern benzodiazepine. So in your opinion, with that perspective, what are the essential elements a clinician should consider when prescribing hypnotics?
Well, I think the thing they have to consider is one, what is the patient's need? Do they have adequate opportunity and circumstance to sleep? And if they don't, hypnotic is not the solution. So you start. So I think you always start with sleep environment and things like that. I think that's critically important. Two, you have to sort of think about how long has this problem been going on, okay, and how often does it happen. So one of the things you have to decide is, are you going to give them a sleeping medication every night? Are you going to give them a medication on a PRN basis, which is very difficult because you got to give them a lot of instruction. And then three, depending on which of those you pick, you got to pick the right medication. And you got to be very concerned. Like for example, people always say, well, you want a short-acting medication. Well, if you have somebody who has insomnia, has anxiety the next day, I'm not sure you want a short-acting medication. So I think you got to get a full picture of the nature of that person's insomnia to pick the sleep medication.
So with that, it's a good leadway to the question about, do benzodiazepines have a role in today's clinical management of insomnia?
Absolutely. There's no question about that. They have a huge role. It is the most common medications used to treat insomnia. Now, people make a distinction between benzodiazepines and the Z drugs. I don't make that distinction.
Okay, that's an important comment.
That's an important point for me to understand.
But so what is the advantage or disadvantage of the traditional benzodiazepine to the Z drugs? Perhaps the benzodiazepines give you more of a variety of half-lives. If you really have an anxious patient, you can give a long-acting benzodiazepine.
Well, okay. So you raise a really, really interesting point there, and I think this is critically important. So the benzodiazepines, it is very important to understand. So there's a series of benzodiazepine receptors, 6 of them. The alpha-1 subunit is the one which is responsible for sleep. The benzodiazepines bind at all of them. And that's why we have benzodiazepines used for depression. We have benzodiazepine used for anxiety. So if you have somebody, now, if you look at the non-benzodiazepine, zolpidem and zalopin make a clear case, and that's Ambien and Lunesta, make a clear case that they only affect the alpha-1, so they have no effect on sleep. I mean, they have no effect on anything beyond sleep. They have no anxiolytic properties. They have no, antidepressant properties. So if you have somebody with, and now S-zapiclone or zapiclone, Imavane, or whatever it is in Mexico, does bind at all of them. So for example, we did a study which shows that if you give them S-zapiclone, which binds at multiple receptors, you augment antidepressant response. If you give them zolpidem, you don't augment antidepressant response. So the difference is the benzodiazepines have a greater array of clinical benefits, while the zolpidem and zalopin, the first non-benzodiazepines, quote unquote, have a very much limited effect.
So when approaching a patient with insomnia, we have talked about CBT and the explosion of CBT, particularly in the literature, perhaps not as permeated at the clinical level because of the lack of availability. But in your mind, what's the role of CBT in the management of insomnia? And should all patients first have CBT prior to being considered for hypnotic medications?
First of all, CBT has its, remember before we talked about what's the nature of your sleep problem, you're just having a lot of wake time. I think CBT, personally, is much better at getting rid of wake time during the night than any other treatment known to man. So if you have a patient spending 2 hours in bed, awake every night, there's no question the way to treat that is with CBT. Now, on the other hand, if you take it compared to medication, it's not as good at increasing total sleep time. So it doesn't increase total sleep time. It increases homeostatic drive. So CBT is much better for me for getting rid of wake time during the night. Medications, by and large, are better at increasing sleep. Now, the advantage of CBT is it's much more enduring. It lasts for a long time with very few booster shots. Hypnotics stop working when you stop taking them.
So I follow up in that line of thinking. Are there concerns in your mind about chronic use of benzodiazepines and or the hypnotics?
There are NIH-funded studies from our laboratory of zolpidem use every night for a year. There's studies by Wally Mendelsohn and esopiclone for a year. Andy Crislow for a year. There's studies way back when with Astaxan, which is a benzodiazepine, for a year. So no, there's no danger associated with the chronic use. Very, very importantly, that's assuming you do not increase dose. If after a month or a day or a week or a year, well, not a day, but after a month or 2 months, if the patient says it's no longer working, you have to stop the medication. So I think they're safe so long as you don't ever dose escalate.
So on a patient who is on a stable dose for months at a time, should the clinician assess the viability of lowering or tapering off the medication, and at what interval would that be a relevant intervention?
I think that's, but the question you're asking is the difference between data and the practice of medicine, right? In other words, if somebody could answer that question, we wouldn't need doctors, we just need a computer who can make week 6, you're off. So again, remember we took that history, how often this? Why did this happen? Did this happen because they had a death in the family? Was that the trigger? Was it because he or she lost a job? And is this every night or multiple nights? And so once you put all of that, so if it's a chronic illness and it's not going to go away anytime soon, there's no reason to stop the medication. But if it's an acute event, which has a timeline, or if the patient seems to be doing better, it's certainly worth it, see if you can take it, skip 1 night this week or skip 2 nights and see what happens. Or take a lower dose.
Exactly.
So I think that's the art of medicine rather than the science of medicine.
And that's an excellent point. I don't think that's communicated enough in clinical medicine, and you see patients on medication with no instruction as to how to handle it long term.
Yeah, try not, I understand that this, when you don't sleep well, you have a bad day. Try not taking it for 1 weekend. You don't have to go to work the next day. And give me a call afterwards and see what happens. Well, let's try a lower dose.
How about the newer hypnotics, the orexin receptor antagonists? Should they play a role in the management of insomnia, and what should their role be?
Well, okay, so there's certain things which makes orexin antagonists different than non-orexin antagonists. The classical benzodiazepine receptor agonists. They work on the wake system. So everything I'm going to tell you about orexin can also be said for histamine, although we don't have any pure H1 antihistamines. They're all also have muscarinic effects. So I'm going to restrict myself to orexin. So the things about orexin is they don't produce sleep. They decrease wakefulness. So let's think about WASA for a minute. So I'm sorry, wake time after sleep onset. How much time you're awake during the night? Mm-hmm. So, and again, this is why history is so important. Well, you're up all night long. Well, I'm trying to understand something, from you. One, when you're up for an hour, are you up 30 times for a minute each? You just keep getting up and going back to sleep? Or do you wake up twice for 30 minutes each? Those both give you an hour of wake time during the night. Well, for the person who's getting up twice for 30 minutes, DORAs or orexin antagonists are outstanding because you can't stay awake for 30 minutes. On the other hand, if you're waking up every minute or every 2 minutes, orexin antagonists aren't going to do very much for you because they don't blunt short awakenings. The other thing that's very important to understand when you're sort of thinking about a medication is when you take one of the classical benzodiazepine receptor agonists, that drug has an effect the whole time you have it in your system. That's not true for orexin antagonists. We've done studies where you wake them up at peak plasma concentrations of a benzodiazepine receptor agonist and an orexin antagonist, and people on a DORA can get up and go to the bathroom, no problem. People at peak plasma concentrations of something like zolpidem will get dizzy and may have fall. So is it somebody has to get up during the night a bunch of times? DORA is the answer.
Okay. So, and
again, this all comes down to your first question, getting to know your patient, getting a good history. How many times you get up at night?
Correct. And so there's the introduction of suvorexant had great promise, but clinically, obviously, it has not delivered. You have made the point over and over again about the FDA guidelines on dosing. So are there other factors that might be contributing to the limited therapeutic benefit reported by clinicians, specifically with suvorexant? And does it imply any concerns about the upcoming auras?
It is very important to understand that, one of the things I always found very interesting is I'm not sure how many of your audience is familiar with the original version of zolpidem, or Ambien, it's called here, I'm not sure what the name is in Mexico, was a single immediate release 10 milligram dose. They then came out with a sustained release, 12.5 milligram, 7.5 initial and 5 later, and it lasts longer. People did not like the 12.5 milligram dose. It's very difficult to get people to switch. It's very important to understand there are many patients who like that knockout experience of the 10 milligrams initially. You are not going to get that with an orexin antagonist or with suvorexin specifically. So you and I work in sleep laboratories, so we have objective assays of sleep. We talk to patients, we have subjective assays of sleep. With benzodiazepines, every one of them, the objective data, okay, is not as good as the subjective data. With drugs which work on the wake system, like histamine, orexin, serotonin, the objective data is better than the subjective data. And so if you're switching somebody from an Ambien, you got to tell them, explain that to them. So the subjective response is not as good to orexin antagonists. And in terms of suvorexin specifically, I think the problem is the dose which was studied in all the clinical trials was not the dose which is approved.
And in that context, the point you're making, which I want to emphasize, is it fair to derive from your comments that the auras are a better fit for WASO patients who are awake during the night? Absolutely. Rather than initial insomnia?
Absolutely. If you're up for a half an hour a shot during the night, this is the safest way to get rid of that and CBT.
Any promise about the upcoming orexin receptor antagonist? Anything unique to be looking for?
Well, as people go forward, one of the ones which just came out has done studies on daytime function, which is being presented at the meeting. It's not that they're uniquely good at it, but they've now looked at it specifically. I think the second one, which is coming out, seems to have a better subjective effect than did suvorexin. But the problem we have is these are industry-sponsored trials, and we don't have comparative trials. So everybody who does a study on DORA, they compare themselves to Ambien, not to another aura. But seemingly there are differences.
Do you foresee potential concerns with the chronic use of the orexin receptor antagonist? Could the intermittent pharmacologic inhibition of orexin receptors pose a problem in the long run?
No, I do not. I do think that big doses of orexin are problematic. So we've had people who abused Ambien and went up to 50 milligrams. If you increase your orexin antagonist by a factor of 5, that's not good. Because
long term or acutely?
Acutely.
Okay.
I mean, you got to remember these are orexin antagonists, and narcolepsy, you can produce a pharmacological orexin knockout. But nobody's ever done that, so I'm not concerned about it. So no, there's not really any concern about that long term.
So, of course, the industry and by default, the clinical approach to insomnia has been fairly effective in the identification and initial management. We have touched on the chronic use of hypnotic medications. What should be the end game in the chronic management of insomnia? I mean, what are the concerns that the clinician who has a patient 5 years on a medication,
I think the
what should
end game has
the
to
doctor
be,
be looking for?
I think the end game has to be, is this making a difference in your life? You know, I think where industry and to a certain extent academics, although not universally, we always talk about, well, insomnia is a risk factor for depression. Well, can we prevent it? And there are now studies doing that. And that's the end game. The end game is improving the quality of life of your patient. If your patient is not saying my life is any better.
The problem is one of the patient, there is an element, I'm not implying dependence, but habituation. It becomes a routine. It becomes kind of the clutch that implies a change of gears. So should the doctor push for what you indicated? Well, why don't you try to drop the dose on a weekend?
And
Try
again,
to
I
break
think
the
that's right.
habituation.
Again, I think that's exactly right. But again, if they have it because they have arthritis, you know, if they have, you know, in other words, if they have a chronic condition which is causing the sleep disturbance or associated with it, then you don't. But if it's due to depression and the depression lifts, I think it's worth trying stopping it or reducing it.
You mentioned something that I always find interesting. I'm not particularly discussed. So as people age, there are all kinds of things that disrupt sleep, that fragment sleep, arthritis, joint pain. So somebody who has insomnia in the context of just discomfort, pain, not major pain, but some pain.
Yeah.
Wouldn't it be right or better to treat the pain rather than use hypnotics to sleep through the pain?
Well, two things about that. One, we don't have particularly a lot of good painkillers. We don't have a lot of good analgesics that we're comfortable using. We really don't want to use opioids very much. NSAIDs have their problem. And there's very increasing convincing data from our laboratory, from Hopkins, that improving sleep augments antidepressant response. I mean, augments
Pain threshold.
Pain threshold. There's no question in my mind that improving, you know, so for example, everybody knows, you know, the clinical benefit of Lyrica in terms of pain management. 50% of Lyrica in a, you know, what do you call it, analysis, in a path analysis, 50% of the efficacy of Lyrica is through sleep. And 50% is the direct pharmacological effect. So I think if a patient has insomnia and some sleep disturbance during the day, I think there's a potential benefit to improving the pain through sleep. And I think it's worth a try. Because we certainly have safer sleep medication than we have analgesics.
Very interesting point. And in concluding, Tom, we of course are living through the SARS-CoV-19, and we have more time than usual to ponder on the present and the future. So what are your thoughts about what will be a generational kind of mark in our lives of what we are going through? How is this going to affect, not acutely, of course, there are people who have adjustments, all kinds of realities out there, but in the long term, in terms of the clinical sleep medicine, research, what's looming in the future, and what are the opportunities more important for young people considering a career in sleep medicine?
I think the opportunities are, one, what we've learned during this era is you can practice a lot of sleep medicine remotely. And it's not unique to sleep medicine, but all medicine. So for example, home sleep testing, which has been starting for a long time, is now going to be dominant. There's a company in Israel which makes this home screening for sleep apnea. I'm not going to mention the name. And I spoke to the company because we were interested in using it for research. And their biggest problem right now is producing enough of them. I mean, literally, there's so many demands. So I think home sleep testing will become a big deal. And I think that's sort of a big deal. And potentially, we're not there yet, but I think we will be there. Right now, we're getting apnea, but we're not getting sleep per se. But I think over the next couple of years, we'll have sleep per se. As all these companies with wearables are eventually going to get us sleep. And one of the things you said, what should we get on a patient with insomnia? If I could get an actigraph that I think is reliable and gives me sleep stages, I think we'll be able to do that. So people have to think about treating more patients, less severe patients. And sleep medicine, post-COVID will become more accessible than it has in the past. It's not going to some place, seeing a doctor for an hour and a half after a 6 month wait and then getting a lab test. Now, there's dangers around that because it minimizes the specialization of sleep medicine. Just because we have a device which can measure respiration very effectively, does that mean anybody can interpret that? I say no. I think not. I think as sleep medicine becomes more available, we have to make sure that its availability is confined to people who understand the specialty. The fact that we can now do all kinds of imaging studies doesn't mean that general practitioners should generally necessarily, or family practitioners, should be doing imaging studies. So I think the challenge will be to get this balance between making broadly available, more home-based, but still under the control of some kind of medical discipline.
Tom, it's always great to hear your thoughts. I have particularly enjoyed the conversation, but that is always the case. And hope to repeat this in the future, perhaps on the topic of excessive sleepiness, which is another favorite. Thank you so much.
You're thrilled. Thank you, Leon. It's great seeing you.